Okay, well, they're figuring out technology. I'm sure, Dr. Wood, this one's going to be easy for you. What are replacement valves made of?
So you can have a mechanical valve, so a purely mechanical valve. Typically now we're only putting that in patients who are kind of in their 30s, 40s, and 50s, who have a congenital problem with their valve. You put a mechanical valve in, that should last many, many years, 30, 40 years. The problem is if that mechanical valve ever fails, we can't put one of our minimally invasive valves inside that. So that's a mechanical valve. And then the other one are bioprosthetic valves, which is what I've been showing you. Both the surgical ones as well as the minimally invasive TAVI ones through the leg. And they're made either through, for cow or pig would be the two most common things. Most of them are pig. So people always ask me, oh, you know, am I a pig now and things like that. But
Okay.
there is some new technology will be purely synthetic. It's very close, but that technology has not made it into humans yet.
Okay, thank you. Thank you. So is bypass surgery the same as valve replacement?
So bypass surgery is the plumbing problem. So again, you've got your heart, size of your fist, you have the 3 arteries, one down the front, one to the right, one to the left. If there's blockages in all 3, and there's lots of blockages, we sometimes might say to you, you need bypass surgery to do that. That's an open heart surgery where they go in and they use veins from the leg or arteries from the chest wall or from the arm to bypass the blockages. That's what a traditional surgeon would do. I don't do that. What we do is if we see blockages and they're amenable to fixing with stents, which I showed you at the start, we would do angioplasty or stenting, same thing. To make the decision between doing stenting and doing open heart surgery is really how many narrowings there are and how diffuse it is. The other big thing is if you have diabetes. The one area that bypass surgery or CABG, coronary artery bypass grafting, is superior to stenting is in diabetics. Just because usually diabetes causes diffuse blockages in the heart, and by bypassing those whole segments, it makes it safer for you. There you go.
Great. Okay, regarding medications that lower blood pressure, what do the different types of medications actually do to lower the pressure? And what do you think about advertising that says after a stroke, take 2 low-dose aspirin and then call a doctor?
There's a whole myriad of different blood pressure pills. There's like 6 different classes. Usually that's what your family doctor is going to work on, your general internist will work on. You don't usually end up seeing me for a blood pressure issue. But as you know, the guidelines for what your blood pressure have recently been lowered. So whereas before we used to be, if you're 140 on 90, you're fine, then it was 130 on 80, then a study came out last year showing maybe 120 on 80 should be the new target, which is interesting because we didn't think that before. And now sometimes they'll even look at your blood pressure ambulatory. So they'll hook you up to a machine and follow you for a few days or sometimes even a month. Or they'll look at your blood pressure with activity. So blood pressure has become a huge target. And as you can tell, I kind of deal with people after all the problems have happened, but fixing the problems up front before they occur, so addressing blood pressure, is a much better way of doing it. And blood pressure, the biggest thing it's going to do by keeping your blood pressure down is going to decrease your risk of stroke. It will decrease your risk of heart attack, but the biggest bang for your buck is stroke. Okay. As far as taking an aspirin, yes. So just like for years we've had, acute heart attack, you need to urgently go to the hospital and have treatment. Now we have code stroke, just like we have code heart attack, where patients come in, they're giving medication to either break up the clot in their head, like a clot busting medication, or now there's evidence in the last 18 months that if you are able to get to a center that has it, interventional neurology or radiology, they can go up and use the same type of wires we use in the heart arteries for the arteries in your brain. And they do something called mechanical thrombectomy, where they go in and suck the clot out of your head. So that's all new as well. So taking an aspirin is a good idea, just like taking an aspirin after having, if you think you're having a heart attack, that's appropriate. Okay. And there's a whole bunch of literature now in communities about looking for the signs of stroke, just like you look for signs of heart attack.
Terrific. Thank you. Michelle, I think you addressed this in your presentation, and you've also talked about early discharges, but in some situations. Someone said that my friend presented stroke symptoms at Sechelt Hospital and they sent him home. Why? And how does the hospital decide who stays and who goes?
So, as I said, I'm not a doctor, but what I can say is that the decision to make a discharge or an admission on a patient is based on a lot of factors. Primarily, it's based on what that physician is seeing with the patient, the symptoms they're displaying, also their history, and they make that best clinical decision on how they feel that patient's care is going to be. And sometimes it is to go home and be followed up with their family doctor or at another specialty clinic, such as the high-risk TI clinic that I spoke about that VGH has. And it isn't an admission to hospital. But all these decisions are made with consultation. So as I said, any stroke patient coming in, the ER physician has had a consultation process with the specialist and talked what they feel is the best treatment for that person. So it isn't a black and white thing that certain patients get admitted and certain patients go home. It's all very individual.
I would just add that's great. In medicine, if you present typically with the usual symptoms, it's much easier for people to diagnose you and treat you appropriately. But if you come in and you're really young and you're healthy and you have no risk factors and you've got funny neurological symptoms, sometimes the diagnosis will not be as easy to make. So a lot of the patients I treat who have the holes in their heart and have a stroke at a young age, they might be misdiagnosed the first time unless it's a very clear-cut stroke. So there you go. And that's the same with the heart. We know that women are misdiagnosed much more frequently than men in all heart disease. Partly because they present differently, partly because the index of suspicion is different. Just like when you're seeing a 38, 40-year-old person, you're not thinking stroke. Traditionally, if you're seeing a 50-year-old woman who's having funny atypical chest pain and shortness of breath, people have not thought heart attack. We now know that that's totally false, and men and women are presenting earlier and earlier. I've done angioplasty on an 18-year-old. I've done angioplasty on a 24-year-old woman who just happened to have very high hereditary cholesterol and presented at a very young age. So again, in medicine, it's always better to be the typical versus the atypical presentation.
Perfect. All right, folks, I think we're going to respect the fact that it's Friday night and everybody probably wants to go home. If we didn't get to your question tonight, we will actually forward them to Gord, Michelle, or Dr. Wood and see if we can get some answers, and we'll circulate them on our website.